Good afternoon. This is Dr. Chaitanya Varma, consultant nephrologist, Global Gleneagles Hospital, Lakdi-ka-Pul, part of Fortis Healthcare. Today I'm going to discuss about post-transplant care. So we all know that renal transplant is a high-end modality, the, uh, the single most important modality in the renal transplant in the end-stage kidney patients. It not only offers the high quality of life and it gives a good survival rate. So if you see the survival rates of the hemodialysis patients, it will be around 5 to 10 years. Whereas you compare it to renal transplant, they can last up to 15 to 20 years if they are they are compliant to the medications uh, and they follow the advices as per the doctor's prescription. Now, coming to the tips of post-transplant renal care. So this care of post-transplant patients should start even before going to the transplant. The patient as well as the family should be highlighted about the adherence to the medications and hygiene methods, hand hygiene, wearing mask, and uh, isolation, and frequency of visits should be informed to them prior to the transplant, and they should be also informed what are the various complications related to the renal transplant. So once we proceed to the transplant, we generally start renal transplant medications 36 to 48 hours prior to the transplant, and then we move ahead to the transplant. So we divide the transplant care into two parts. It's early, which is immediate post-operative period, or we can say the early transplant care, which lasts about till 1 month, and from 1 month to 1 year, the long-term care. So once the transplant is being done, the patient will be in the hospital for 7 to 10 days, depending upon the type of transplant, whether it is a live or this is renal transplant. And during this period, the nephrologist and urologist and anesthesia or ICU team will be monitoring various parameters, whether it may be hemodynamic parameters like BP, heart rate, respiration, and other the urine output and the other parameters. These will be monitored throughout the day for the first 2 days, and then the patient may be shifted to the patient initially will be in the ICU. So initially the first 2 3 days will be the ICU care, then the patient gets shifted to the ward. So whatever maybe the transplant type, so the nephrologist or urologist try to remove the catheters, which may be the vascular access catheters or urinary catheters or stents as early as possible to prevent these infections, because they are the source of infection. And during this period, he will be mobilized after 2 to 3 days. He will be mobilized, and by the end of the seventh day, the patient seventh or 10th day, depending on the transplant, the patient may be fit for the discharge. So during the discharge, he will be given a lot of instructions. In fact, the moment the patient gets transplanted, 1 day 2 days, once the patient gets shifted to the ward or once shifted from the ICU, he will be counseled regarding the oral hygiene. So he should be should brush the teeth daily, twice daily, and also the bladder care. The catheters, Foley's catheters and trials, all this will be out by maximum 5 to 6 days, depending upon the institution protocols, and they will be advised not to withhold the urine, as it may be the source of the infection. After this, he will be advised to sanitize the hands, to wear mask, and to preferably to stay in the isolation period for at least 3 months, as the next state of immunosuppressive therapy will be very high during this period, and the probability or propensity of infections will be very high during this period. So during this period, he should be very cautious, and we most of the patients will reside in the same city for 3 months, because the during this period, not only the patient comes to the hospital, and the patient will be asked to bring some blood tests, urine tests, and some tests regarding to the levels of the drugs, immunotransplant drugs, so which will be monitored by the nephrologist. So these are all things should be kept in mind. And once the patient gets discharged by seventh or 10th day, frequency of visits may vary depending upon the institute. We generally follow initially every third day for the first 2 weeks, and then once in a week for the next 2 months, and the months in 3 weeks for the next 3 months, and thereafter every monthly till 1 year. Once the patient reaches the 1 year post transplant, it will be on 3 monthly basis. We will be calling him. When we call him and we call these patients back, we'll be not only seeing uh, the lab reports, the urine, blood tests. We'll be also the patient should be having the record of weight, intake output, and any issues related to the medications. All this should be addressed by the nephrologist. So most important in the post-transplant care is the adherence to the medications. So there are a lot of medications which should be taken to the throughout the life, particularly three medications, uh, CNIs, MMF, and steroids. So these drugs should be taken at a fixed timings, and the uh, they should not be taken with other medications, or they should not be taken with food, because the efficacy of these drugs decreases if we mix with other foods or drugs. So they should be very vigilant and compliant when considering these drugs. The drugs, certain drugs which we prescribe in the post-transplant period may require frequent monitoring. So particularly CNIs like tacrolimus and cyclosporin. So these levels should be, the nephrologist will have a check on these levels, and we will advise the patients to get the blood report of these levels. So the patient should remember this. The level should be of the tacrolimus particularly. We generally ask the patient to give the sample 20 minutes prior or 50 minutes prior to the next dose. So they should remember. Sometimes we get the patient saying, "I have not given this sample correctly," so it doesn't serve the purpose. Afterwards, there will be a lot of medications regarding the prophylactic care, because the patient is put on immunosuppressive therapy. So oral antifungal cream should be kept on for 1 to 3 months. Some antibiotics for 3 to 6 months, and antiviral 6 months. These 3 to 6 months, the protocols may vary, and the maybe the baseline antibiotic for 1 or maximum 5 to 10 days. So these are the drugs we generally focus in the post-transplant period. These drugs, we can switch to other immunosuppressive therapy depending upon the clinical status, lab parameters. So these the nephrologist will be monitoring and changing the medications according to the clinical condition. After the drugs and frequency of visits, we focus on the activities and diet. So in general, when the patients normally get mobilized within 3 to 5 days post transplant, and they can resume their own activities like minimal activities and the household activities by 1 month, and they can perform even the aerobic exercises like walking, and but the restraining exercises are generally avoided in the initial 3 months, because the surgical side, the wound healing will take place. So these exercises generally we advise them to take after the 3 to 6 months. So these aerobic exercises will have a good impact on the cardiovascular profile, and they will also reduce the weight and fat composition. And compared to the resistance exercises, they generally focus on the bone health and muscle health. So these are the activities, and which we should remember while in the post-transplant period. So, but certain activities like contact sports, rugby, and kabaddi, all these things should be avoided. And swimming can be taken after 3 months or 6 months, but it's not only about the swimming, but the avoiding overcrowding places like pools or any theaters, or wearing mask. All these things should be kept in mind. So prevention, as we know that prevention is better than cure. So this implies in the post-transplant care also. So please, the post-transplant patients, you should focus on all of these things. Coming to the diet, as opposed to the hemodialysis patients or in the CKD as CKD patients, in the CKD patients, we advise them to take restrict the protein, and in the dialysis patient, we ask them to take more protein. Here it is an in between. So in the initial few days, because of so many drugs and steroids and all these things, the calorie intake can restrict up to 30 to 35 kilocalorie per kg per day, and the protein intake can maximum can take up to 1.5 to 2 gram. In the later 6 months, we can reduce it to 20 to 25 kilocalorie per kg per day, and the protein of around 1 gram per kg per day. So this should be our dietary chart. And when focusing on this diet, please avoid consuming this unpasteurized milk or undercooked meats. So as these may lead to the GI infections, because as the most of the patients will be on this immunosuppressive therapy, so it will be very dreadful to deal these situations. So avoid outside food, take good hygiene measures, and wash your hands and wash your the fruits, vegetables, everything which you get, and lead a healthy and happy life. Coming to the all after coming to this after completing this diet, exercise, and frequency of visits, now we focus on the other parameters. So in the post transplant period, the cardiovascular complications and the infections are the most uh, common complications. They contribute to 50% of the mortality. So infections particularly, there are a lot of infections. It is divided according to the uh, time of transplant, earlier transplant, rather than 1 month or till 1 to 6 months and more than 6 months. Points to note are: be aware of what are the precautions to be taken, hand hygiene, mask, wearing mask, and the prophylactic antibiotics or antivirals which we advise in the post-transplant period, they should be taken without missing. And the most notorious complications which we generally notice in the post-transplant period, such as UTIs, the pneumonias, and the early transplant. And if you go for further, the CMV, BK virus infections, and then rest all PCP pneumonia, other viral infections as hepatitis B, hepatitis C, even the TB infection gets uh, TB is also one of the most common infection in the post-transplant period. So infections are very difficult to handle in the post-transplant period, because if you there should be there is a very delicate line in treating these infections. If we treat more, the infection chances will be high. If you treat less, the chances of rejection will be high. So that is about the infection. Coming to the emergency sense, which you should know in the post-transplant period. So specific mention about the rejection. Rejection is nothing but that organ which you got donated is the your body is not accepting that organ. So the signs will be subtle. Sometimes there will be fever, localized tenderness, that means the graft tenderness, and there will be decreased urine output, weight gain. All these things will point towards the rejection. So consult the nephrologist immediately if you have these signs. And even in the early transplant period, if there is extreme graft site pain or when there is hematuria, decreased urine output, this is a very dreadful emergency, the thrombotic manifestations. You should definitely consult your nephrologist. This is life saving also, because it's not the kidney. It's sometimes it can take the patient's life also. So these emergency complications should be kept in mind. And after these infections, rejections, now coming to the other complications such as diabetes, hypertension, obesity. So they contribute around 50 to 70%. Diabetes, particularly in the early transplant period, so people, it's better to use insulin rather than using the other oral hypoglycemic drugs initially in the post-transplant period. And in the post-transplant period, if you want to pick up a diabetes, particularly in the earlier few months, 3 to 6 months, it's not the HbA1c. you should focus on the fasting profiles at the you should go for the oral glucose tolerance test. So that is about the diabetes, and this diabetes gets very the risk factors are so many risk factors are there, but CMV infections, hepatitis C, and low magnesium levels can aggravate this diabetes. Hypertension, hypertension as like any other patients or any CKD patient, these patients are more prone to the hypertension. So low salt diet is definitely advised, and in this post-transplant period, so one should have a look on onto the renal artery stenosis. So if the BP is not being controlled after addressing all the factors, please there is there is an entity called stenosis in the renal artery which should be addressed. So the treatment modality may vary. Sometimes some nephrologist may prescribe beta blockers, calcium channel blockers, and some of them when there is a proteinuria component, they add ACE or ARBs ACE or ARBs. So this is about the management and the hypertension, management of hypertension. So now coming to the lipid profile, at least yearly once lipid profile should be checked. And the next comes the reproductive and reproductive healthcare. So normally, uh, all these patients who are on CKD or dialysis, they have some the quality of the reproductive life will be not that good. The spermatogenesis, the erectile dysfunctions, and the menstrual irregularities, all this will happen because of the high creatinine, high uremic levels. So once the patient gets transplanted, most of them will get reverted, and most you can resume the sexual activity by three to 6 months, maybe 6 months, 3 to 6 months. And coming to the if you want to, the couple want to become pregnant, or so there are certain things you should keep in mind. uh, at least 1 year post transplant, it is ideal to go for a pregnancy or conception. Patient should be on a stable immunosuppressive therapy. No recent evidence of any rejection or a treatment of rejection. And the creatinine should be maybe better. It is less than 1.5. Proteinuria should be less than 500 mg. And the immunosuppressive therapy should be on the stable doses or minimal doses. So these are the prerequisites of the for the patient who had conceived. And if the patient is already on, by chance, if the patient had some recurrence of the glomerular disorders, the patient is on cyclophosphamide, it's preferable to stop the cyclophosphamide at least 3 months before conceiving. In the male patients to become fertile, at least 1 to 3 months. And other immunosuppressive therapy, uh, MMF, and all this should be converted to azothioprine. At least 6 weeks prior, MMF should be withheld before conception. So this is about the reproductive health care. And during this entire post-transplant period, the patient will be an immense uh, stress or anxiety. They contribute around 50%. Depression, anxiety, all this will contribute. So family support is required at this juncture. So throughout, even in fact, pre-transplant, transplant, post-transplant, they should be he or she should be having the proper family support, so that all these things will get addressed. And coming to the cost burden, so I said earlier, it's not about the post-transplant care starts even before the transplant. So the cost issue should be addressed regarding the cost of the transplant and long-term immunosuppressive therapy. It will be around 10 to 15,000 per month. So all this should be addressed before the transplant, so that there won't be any hurdles post-transplant. And after this, special mention about the vaccines. The vaccines, in general, live vaccines after the transplant are contraindicated. If you want to go for killed vaccines, 3 to 6 months post transplant, it is the ideal time to go for the vaccine, particularly the killed vaccines. And the other things, uh, if you focus on the obesity, because the uremic milieu has been removed and the uric patient is put on a number of medications, steroids and all these things, the appetite will increase, uh, and so the patient will be eating a lot. So this should be controlled. Eat a healthy diet, take a uh, good diet containing all vegetables, fruits. Don't eat fried fruits, fried vegetables, or fried products. So this will keep you out of this uh, gastric upsets. So sometimes we get confused whether it is due to food poisoning or due to the effect of the drugs. So avoiding all this will reduce the admissions, and it will make the quality of life more better, much better. So what I would like to say it's not a single time process. It's not a single day event. It's a lifelong commitment for the from the patient, family. So and then of course the doctors, nephrology and urologist team. So what I request you is when you are having any issues or problems related in the post-transplant care, please free to approach your nephrologist and address the issues properly. And coming to the, I take this platform to just highlight you regarding the renal transplant status in our India, in our country. So it's about 1,300 transplants are being done in 2024, and maybe near to 11,500 are about live related. Hardly 1,200 transplants are being deceased renal transplants. And predominantly, the southern states, particularly the Telangana, is doing very well in the deceased transplant program. So I would like I would request you to log into the site of the Jivandan and have a look on it, so they will get a broader idea. So what's happening in the world and what's happening in India, what's happening in our states. So we are ranking around. We are about the third. We are after US and China. I think it's India and the renal transplant program. So, but the demand is too high. It's about 80,000. Do, the demand is about 80,000, and particularly renal transplants are contributing to 60,000. So you should understand the immense importance of the renal transplant program. So I would request you to please join the site and have a greater idea on this section. Thank you so much for your time.